Good afternoon, everyone. My name is Brandy Jo Edwards, and I am a family nurse practitioner student with the University of Phoenix. I will be presenting a case study on a 20-year-old female diagnosed with hypermobile Ehlers-Danlos syndrome, or HEDS, as a part of my NRP 590 final preceptorship. All right, so this case involves a 20-year-old female college student who was diagnosed with HEDS at the age of 19. She presents to the clinic with worsening joint pain, frequent subluxations, abdominal pain, amenorrhea, and chronic fatigue. These symptoms are significantly impacting her activities of daily life and her academic responsibilities. While there is no confirmed family history of HEDS, her mother does report that she has joint hypermobility, which could be an indicator of an inherited predisposition for HEDS. Ehlers-Danlos syndrome, the overview. Ehlers-Danlos syndrome is a group of inherited connective tissue disorders that primarily affect collagen structures and function. They cause mutations in genes like the COL1A1, COL1A2, and COL5A1, which disrupt the collagen synthesis, which leads to weakening connective tissue. This results in skin hyperextensibility, joint dislocations, tissue fragility, and poor wound healing. The hypermobile subtype, HEDS, is the most common but lacks a non-genetic marker, which making the diagnosis clinical rather than genetic. And then history of present illness. The patient's primary complaint is worsening joint pain, frequent dislocations, and chronic fatigue, which has been progressively worsening over the past 6 months. The pain primarily affects her knees, shoulders, wrists, and fingers, and she rates it about a 7 out of 10 on a pain scale. While rest provides some relief, physical activity and prolonged standing exacerbates her symptoms. And she has also previously tried NSAIDs with minimal relief and attempted physical therapy, but it was discontinued due to too much pain. She wasn't able to tolerate the physical therapy. And moving on to pertinent positive symptoms, we got the review of systems for this patient. The patient's review system reveals several pertinent positives, including joint hypermobility, frequent dislocations, chronic fatigue, and bruising, delayed wound healing, dizziness suggestive of POTS, and gastrointestinal symptoms such as bloating and constipation. However, there are no reported fevers, weight loss, rash, syncope, or recent trauma to the patient. Past medical history. This patient was diagnosed with HEDS actually at the age of 19. I'd said after experiencing frequent joint subluxations and pain since childhood. She also has a history of suggestive of POTS, which migraines since the age of 17, and GI symptoms consistent with dysmobility. Her current medications include NSAIDs as needed, a multivitamin, and a magnesium supplement at this time. Some physical exam findings. On physical exam, the patient appears well and in no acute distress. Notable findings include hyperelastic skin, soft tissue fragility, and easily bruising with mild atrophic scarring. A Brighton scale of 7 out of 9 confirms significant joint hypermobility. The cardiovascular findings include mild tachycardia. Her heart rate was 105 beats per minute, and she did have a bit of orthostatic hypotension at this visit. And then we'll move on. Diagnostic testing and results. Since HEDS is a clinical diagnosis, genetic testing was not performed. An echocardiogram was normal, ruling out vascular EDS. MRI imaging did not show any structural joint abnormalities, and further supporting the clinical diagnosis of HEDS for this patient. This patient was sent to a gastroenterologist for her abdominal pain. She has recently undergone an EGD and a colonoscopy. The findings of the EGD were a 2 centimeter hiatal hernia, and the colonoscopy had no visual anomalies. There were several biopsies performed during the colonoscopy and sent off for testing, but no results are available at this time. Okay, moving on to some differential diagnosis. The primary differential diagnosis considered for this patient would include the hypermobility spectrum disorder, HSD, which it lacks systemic manifestations that are seen in this patient and seen in HEDS. Marfan syndrome is characterized by long limbs, cardiovascular involvement, and different genetic mutations, in which this patient doesn't have any genetic mutations that are notable because with HEDS there are no known genetic mutations. And then osteogenesis imperfecta is a collagen disorder associated with brittle bones and fractures. And then also rheumatoid arthritis could be a differential diagnosis for this patient, which it presents an inflammatory joint pain but lacks the hypermobility that is seen in this patient and is seen in HEDS. So ultimately, the patient's clinical presentation aligns with the diagnosis of HEDS. All right, we'll move on. If I can get it to move. Okay, so for the plan of care for the patient's management plan includes education on joint protection and appropriate exercise techniques, medications considerations such as gabapentin for neuropathic pain, and a trial of propranolol for POTS syndrome. Referrals to physical therapy for joint stabilizations, cardiology for POTS assessment, and gastrointestinal for dysmotility symptoms, in which this patient has been sent to the gastroenterologist, and we are actually waiting on test results from those biopsies that have been sent in on her. Close follow-up for the patient to monitor pain levels, function status, and treatment response. A multidisciplinary approach is crucial for management of HEDS and its associated conditions. Okay, so another aspect of this presentation was to talk about the nurse practitioner authority in the United States. And nurse practitioners has varying levels of practice authority across the United States. Some states grant full practice authority, allowing NPs to diagnose, treat, and prescribe independently. Others have reduced practice, requiring some physician oversight, while restrictive practice states mandate physician supervision for certain aspects of care. Okay, so for the state of Arkansas, in which that is where I live, I'll be practicing once I finish. Nurse practitioners operate under a restricted practice model. This means that nurse practitioner must have a collaborative agreement with a physician to diagnose and prescribe certain medications. This regulation can limit access to care in underserved areas where physicians' collaboration may be difficult to obtain. Some physicians are not as easy to obtain and want to work with practitioners as some will. All right, so for an example for physician agreement, under the Arkansas law, of course, nurse practitioners must have a formal collaboration agreement with a physician. This agreement is a legally binding document that defines the scope of practice for the NP. Additionally, there are prescribing limitations on Schedule II controlled substances, and it requires the oversight of the physician. These restrictions impact NP autonomy and patient access to care, particularly in the rural areas or the rural communities where some physicians are not quite adapt to having an NP or working with an NP. So, in summary of this case highlights the complexities of management hypermobility and Ehlers-Danlos syndrome. Given the broad systemic manifestations of HEDS, multidisciplinary and patient-centered approach is essential for taking care of patients with HEDS. Additionally, understanding NP practice authority is critical for optimizing patient care within the legal scope of practice. And just being aware of what you can and cannot do in your state to practice. So thank you for your time, and I welcome any questions that anyone may have. My next two slides are actually just my references where I've gotten my information. So thank you for your time and hope that you learned something from my PowerPoint. Thank you.